common misconceptions that after gastrectomy or during gastrectomy or before gastrectomy, initially we used to keep commonly known as the rice tube for long time. Is it really required? See, rice tube, we feel it's a benign procedure, but it has its own complication. You can see in this patient. You can see this tube, rice tube is going into lung. So rice tubes are not complication free. You have to be very careful and insert rice tube for proper indication only. These are the various complications of inserting the nasogastric tube or rice tube, that is hepatitis, sinusitis, gastritis. Sometimes it can perforate the stomach also. Aspiration pneumonia is also there. So initially it was believed that rice tube insertion can be beneficial in gastric decompression. It can decrease the nausea and vomiting. It can decrease the abdominal distension, lesser chance of wound infection. Also, it used to say that it decreases the incidence of postoperative ileus, but it is not so. It actually increases the postoperative ileus formation. Let us see what the evidence or data says. So, in this systemic review and meta-analysis, 33 trial was checked, consisted of 5,240 patients. Patients were randomly assigned to no gastric or early removed within 24 hours. Versus standard gastric nasogastric tube rice tube placement. Generally, we keep rice tube until patient pass flatus. So, in no tube group, actually, bowel function returned earlier. There was lesser pulmonary complication. There was lesser wound infection, though not statistically significant. There was decreased length of hospital stay. Yes, little bit vomiting was increased in no tube group. However, in tube group, vomiting was less, but patient discomfort were increased. So, no tube group was actually more beneficial and was associated with lesser hospital stay. So, rice tube should be inserted whenever necessary for proper indication. Generally, in post-op patient, prolonged rice tubes are not necessary. There is another meta-analysis of 5 randomized control trials. So, time to oral diet when patient can take orally was significantly lesser in no rice tube group. So, routine nasogastric tube decompression is unnecessary after gastrectomy. This is the main message I want to give for people who are caring for these patients. Okay. So this is another study. Again, no difference in leak rate. No increase in other complication in patients who are not assigned the rice tube. So rice tube does not give any benefit and may harm. There are certainly benefit in patient who does, we do not keep prolonged rice tube. So prolonged rice tube should not be given. So earlier in 1800s or 1900, we keep rice tube for long. I still see that practice going on, but that practice should not be done. It can increase pulmonary complication. It does not speed return of gastrointestinal function earlier. Ideally, it should be removed within 24 hours post-operatively. And yes, sometimes when we staple the stomach after cutting it, for cutting it, rice tubes are in the stomach, and that can hamper your proper sealing of the stomach and can lead to anastomosis leak. So when you are when surgeons is stapling, you have to be very careful that rice tube is not in the way of surgical staplers. Now, another postoperative standard postoperative protocol which is used recently is the early recovery after early or enhanced recovery after the surgery. You have to ensure proper perioperative nutrition. Prolonged fasting before surgery is not required. Generally, 2-hour fasting for liquid and 6-hour fasting for soft diet or semi-solid is adequate. You have to ask patient to stop smoking. You have to give subcutaneous deep vein with thrombosis prophylaxis, enoxaparin or any other anticoagulant available. Right? Avoid prolonged surgical approach should be as quick as possible. You should respect surgical plane. Perioperative fluid management, patient should not be overloaded or underloaded. It is generally goal-directed fluid therapy. According to urine output, whatever your criteria is, should be followed. Post-operative prolonged bed rest should not be given. Early mobilization is the key for recovery in this patient. Generally, if you are kept on drain should be removed early. Patient should be given food as soon as possible. You should not wait until the patient passes flatus or return to bowel activity. NPO status is harmful. It is age-old belief that NPO should be done, but more and more evidence has proven that nil per oral is not a good strategy to follow. You should have good control and good sugar control. Post-operative glycemic control helps in preventing the surgical site infections or wound infections also. Now, common complication after gastrectomy is bleeding, anastomosis leak, and pulmonary complication. Bleeding are generally from the short gastric artery, as you have mentioned. Now, how to achieve a better survival? See, whenever you are operating, I always say that complication is a part of surgeon's life, but how you manage complication is much more important. There are many success stories where patients are offered gastrectomy and there is no post-operative event. But you are not tested in this condition. You are tested when complication occurs. So let me share a case with you. A 50-year-old man came with serious stomach. It was resectable on lesser curvature. We planned distal gastrectomy with D2 lymphadenectomy. So it was a major surgery. On post-operative day 2, patient certainly had hypotension. HB was fallen to 5. So we know it was interoperative. Some bleeding is going on. We immediately opened the patient. So re-exploration is not your defeat. There is no shame in re-exploration whenever patient required. There was bleeding from short gastric near upper part of the greater curvature at the splenic blade. Splenic near the diaphragm, I would say. So we controlled that bleeding. Patient immediately improved hemodynamically. But due to that bleeding, blood supply to the anastomosis might have hampered. The patient developed anastomosis leak. So there is another complication. Now, generally, when anastomosis leak is in less output, we unnecessarily keep patient in prolonged nil per mouth status. But as it was a low output fistula, we call it the stomach fistula, we started orally. Gradually, we even started with leak normal diet. Patient gradually improved, that leak stopped. Patient was having cancer. Patient just came a week before in my OPD after 5 years of surgery, and still now, by God's grace, there is no recurrence of the cancer. So timely detection and management of complication is all that matters. Rather, no surgeon can avoid. If literature says 2% complication, says you are going to face complication in 2% of cases. It is how you manage that makes all the differences. I think, thank you very much. That was a brief about gastrectomy. If any question, I will be happy to take.